Welcome back, everybody, and welcome to the Quality and Service Improvement session. And I'm delighted to be able to introduce our first speaker, Dr. Bernard Brett. Bernard's very kindly agreed to speak to us about quality improvement initiatives in gastroenterology from the BSG perspective. So Bernard is the Quality Improvement Lead for the BSG and also Secretary of the Clinical Services and Standards Committee. And he's held many senior medical management posts, but is currently Deputy Medical Director at Norfolk and Norwich University Hospital. So with many interests, Bernard's particularly interested in service transformation and reconfiguration, and is co-author of the BSG's Job Planning Guide. So all in all, a very helpful man to know, and we're very delighted that he's agreed to come and talk to us today. So very much looking forward to your talk, Bernard. Thank you very much.
Hello, I'm Dr. Bernard Brett, and I'm here to talk about quality improvement initiatives in gastroenterology, a BSG perspective. And I am the BSG Quality Improvement Lead and CSSC Secretary. So what I'm going to try and cover today is just give an overview, describe the current context, talk a bit about the CSSC itself, a bit about BSG guidelines, spend most of my talk on the quality standards framework, and then talk about linking in with other initiatives, and finally talk about quality improvements going forwards. So the BSG Clinical Services and Standards Committee, supported by the BSG Executive, has a main focus on quality improvement, and please, if you haven't already done so, visit the website. The link is here, and you will find all sorts of relevant documents and articles which are all linked to quality improvement. Let's think about the current context. The COVID-19 pandemic has, of course, affected us all, and not only has that affected our workforce, many having to do many different things, many feeling exhausted by the strain of it all, it has ended up producing a huge elective backlog. And although this has led to a slowing of progress in some areas in terms of quality improvement, it's also provided a big chance to adopt, adapt and abandon. And been a rapid rise in a range of things such as virtual clinics, virtual group clinics, the use of advice and guidance to help improve quality and control demand, and the use of FIT to triage and prioritise colonoscopies, just a few examples. Despite the COVID pandemic going on, the pilot sites for the quality standards framework have still been working in areas that were possible during this time period. And I noticed that you've got Bev Oates talking later today, of course. The Get It Right First Time report for gastroenterology is in its final draft or just about to be published, and that's got some key recommendations for us all to reflect on and work towards in terms of quality improvement. I think another thing to mention in terms of the current context is, of course, workforce. We know that there have been difficulties and remain difficulties in terms of recruiting key individuals, particularly consultants in gastroenterology and hepatology. What about the CSSC? Just for those of you who don't know about it, we have representatives from each region and from the 4 nations. We respond to consultations from a variety of bodies such as NICE or Health Improvement Scotland. We promote and encourage and support regional gut clubs. And of course, we guide and encourage and provide the support to develop guidelines, guidance and toolkits to help our members and help people deliver a high quality service. We are working on the quality standards framework, and I'll talk more about that later. And we are very much about sharing good practice, and that's through the symposia, webinars and service development prize, as well as what's on the website. And importantly, we need to link in with all related activities already mentioned, things like Get It Right First Time and iQuils. So the BSG guidelines are currently led by Rupert Ransford. And it's worth saying that gut has risen to its highest impact level at 19.819. And this is due to the excellent leadership of Professor Imad El Omar. And he states that he thinks one of the reasons for this is the very high quality BSG guidelines. And these are approved by NICE. Here's a range of the things that have been produced in the last 12 months or so. Important guidance regarding rebooting gastroenterology and hepatology outpatients in the wake of COVID-19, guidelines on the use of liver biopsy in clinical practice, tips in the management of portal hypertension, the management of adults with severe chronic small intestinal dysmotility, the management of ascites and cirrhosis discharge bundles, etc. And I will mention again briefly the acute upper GI bleeding care bundle later on in the talk. So these are just a few examples of the guidance that has been produced to support our members. I talked about sharing good practice, and I hope some of you were able to read about or view the webinar with the CSC Service Prize winner, the nurse-led day case gastroenterology service in Wolverhampton, presented by Sham Menon and his team. A superb example of how the length of stay of patients and the quality of service and the patient experience can be improved greatly. And this is a key thing for us to think about, particularly as we consider the pressure for beds that has been present for many years and likely to be an even bigger factor this coming winter. So we've also had a presentation from the runner-up group clinics for celiac disease. Again, a really important quality improvement movement here, because if we move to group clinics, not only can we deliver more efficient care, in addition to this, we can actually produce a better outcome for patients. There is evidence there that patients have a better experience from group clinics, so they can hear questions their peers ask. This can lead to better understanding and better outcomes. At our recent webinar, we had a presentation from Professor David Saunders from the Sheffield Teaching Hospital Unit, and the presentation regarding how they've managed to achieve World Endoscopy Organization's Centre of Excellence status, which has taken an awful lot of work and really impressive talk, and something for other units to consider. What about the quality standards framework? Well, I think we all have a pretty good idea what good looks like, and most units have areas of excellence, but services that are less good and definitely require improvement. And we know from the CSSC surveys that there is a huge amount of unwarranted variability in the provision of a range of services, from GI bleeding, out-of-hours endoscopy, IBD nursing staff, and alcohol services, to name but a few. And the aim of the quality standards framework is to reduce this variability and enable the development of our clinical services through the encouragement of excellent, safe clinical practice, with the ultimate aim of reducing clinical error and poor clinical outcomes. So we want to aim for excellent outcomes for our patients. I'd like to really consider how this relates to, for example, the GRS and quality improvement in endoscopy, where many units started just about being able to hit the lowest ratings on the scale, but with significant work, most units were gradually able to improve their services and improve their ratings across the whole range of markers there. So what will the quality standards framework look like? It's still in development. It's still being gradually implemented through the pilot site and fine-tuned. Each standard will have different levels. A bronze level, which should be achievable by many, often with relatively limited work, and a gold, the standard that all units should strive for, but most, if not all, will have to work significantly harder to achieve. And in the end, we will try and set a midpoint on the scale, which would be the silver rating. Each standard will have clear descriptors and or measurable figures, and indeed a guidance regarding what sort of evidence would need to be provided. Each standard is developed with the 4 nations in mind and will recognise the differences in larger and smaller units. And each of these may need to achieve slightly different things. So, for example, a larger unit may need to provide evidence that it is supporting smaller units in the delivery of tertiary services for the population. The overall achievement would probably be based on a composite score. So the Clinical Services and Standards Committee, along with the BSG executive, launched the project back in 2016, and it has involved a whole range of key stakeholders, including patient and patient groups, BSG sections, the representatives from the regions and the 4 nations, and Get It Right First Time and the RCP accreditation unit. So there have been multiple meetings as this work has developed, and the framework has been developed thinking about past experience, but also looking at other standards out there, such as CQC standards and the KEO standards. And as I said, it's been coordinated with other key pieces of work. The pilot sites, the extension for the pilot sites has been necessary because of the COVID-19 pandemic. So we were originally due to finish this year, but this has been extended for a further year with an aim for national implementation from 2022 onwards. And the NHS really does provide a good opportunity to develop and implement the quality standards framework. What does it look like? Well, if we think about the Lilly principles, the 5 gets for patients: get in, get seen, get fixed, get out, and get on. And these fit into the 5 original domains, but we've also added 2 additional domains to support these patient-focused areas. So the original domains are access, so get in, diagnostics, interventions, get fixed, re-enablement, ambulatory care and transition, get out, and the monitoring, surveillance and secondary prevention is the get on domain. But in discussion with the development group, we felt it was really important to add the domains of education, training and CPD, and research and innovation. So the 17 current standards are likely to have 3 additional standards added to take account of these domains. And the aim is that this should encompass the whole of gastroenterology and hepatology services. And just to think about this, if we think about diagnostics, this would, for example, talk about timely access to endoscopy, radiology, and laboratory and pathology. The diagnostic practitioners should be accredited by the various national bodies to meet the standards. And again, for diagnostics, there should be access to subspecialist radiologists and histopathologists where required. The interventions will be based on other things that are already out there, such as IQLS and IBD from IBD UK, nutrition interventions. Charlotte Pither is leading on this, and the upper GI bleeding guidance and care bundle that John Morris and his team developed. So there's just some of the examples of what it would look like. Let's go into a bit more detail. So if we think about standard 5, there should be timely and appropriate access to diagnostics such as endoscopy, radiology and laboratory, and that should be applied to both inpatients and outpatients. So the recommended evidence should adhere to the relevant national societies and guidance. I'm not going to go through this slide in absolute detail. I'm just going to give you highlights. And the toolkit would be to see the relevant national endoscopy standards, JAG documents on appropriate of endoscopy, BSG guidance as well. And this would map to other areas such as Get It Right First Time, and then appropriate evidence would need to be provided. So if I just break that down even further, so if we think about this standard, it relates to the KEO 7-day services standard, and this in quotation marks at the top. Hospital inpatients must have scheduled 7-day access to diagnostic services such as X-ray, ultrasound, CT, MRI, echocardiography, endoscopy, bronchoscopy and pathology, and this should be within 1 hour for critical care patients, within 12 hours for urgent care, and 24 hours for non-urgent patients. And this is just a working view on how this might work. This needs to be developed with the pilot sites before we can determine whether this is achievable. But the gold standard would, of course, be challenging for most units. And what we're currently thinking is that all 3 of these would need to be met 7 days a week with an audit evidence for 90% achievement, which really is challenging. The bronze standard would recognise that there is that there's a long way to go, but during the week all endoscopy requests should be reviewed and either undertaken, bowel preparation commenced, or arranged as an outpatient to facilitate discharge within 24 hours, and that would be 90%. And at weekends, we're suggesting that this should occur within 48 hours, i.e. suggesting that this would need to happen at least once during a weekend period. This could be supported by virtual review and network solutions, and not necessarily by each individual unit. As I say, this example is not finalised, but gives you some sort of idea of the detail. Bev Oates is talking later today, and there is going to be a national drive for implementation for all or most specialties at pace to help address the difficulties for elective services which they face now and are likely to become even more marked during the coming winter. And there'll be a real focus on preventing admission, early discharge, short lengths of stay, and elective pathways. So what might that mean for gastroenterology? It might mean a move to more 7-day inpatient working for assessments and diagnostics, implementation of appropriate assessment and triage of referrals for outpatients and endoscopy, which might also include more advice and guidance, as well as accelerated inpatient patient pathways. And these pathways will be broadened to try and include the avoidance of admission. In terms of the quality standards framework, all 4 nations are represented, and we've got a mixture of teaching hospitals and district general hospitals, and Sunil Dalwani from Cardiff has been one of the key people involved in the development group. And these are the other people, or some of the other people involved in the development group. Some top tips that have already been developed aim to get consultants, senior management and mid-senior management on board as soon as possible. If we get buy-in, then we're more likely to reach success. It is important that there is appropriate admin and informatics support to develop the quality standards framework achievements. And it's important to identify appropriate work stream leads. A baseline mapping exercise is helpful to identify the gaps, and really critically, I think, involve the trainees, involve the specialist nurses, involve the trust doctors. Picking off the low-hanging fruit can help to build momentum, and we need to make sure that the basics are in place across the board to deliver optimal patient care. And some of the pilot sites are using non-consultants to lead on some of the work streams, and this can be a real opportunity, a development opportunity for those members of staff. So in the future, the pilot site reporting will continue and give further feedback to the BSG and its members. There'll be refinement of the framework, clear descriptors for each of the standards, and the addition of the final 2 domains. And for anyone who's keen to get involved, please contact me. The more input, the better, as we take this piece of work forward. A whole range of people have been involved in the quality standards framework, not least Andy Dowes, Rupert Ransford, Alison McKinley, Tony Tam, who's talking later today, the 4 leads for the 4 nations, and there's a whole list here that need to be mentioned. You've got Bev Oates speaking later today, Tim Briggs, obviously, with his work on Get It Right First Time, the BSG the staff itself, including Simone Court. Going forwards, the BSG Clinical Services and Standards Committee will continue to encourage and promote quality improvement and provide guidance and support. The Quality Standards Framework will continue its development, and will work hard to link it to other areas so everything is aligned. The get it right first time work, really interested to hear Bev Oates talk later today, is also extremely important. Please get involved for your local unit and through the BSG. It is so important that we all strive to work towards quality improvement for the benefit of our patients and our population. Thank you very much indeed for listening to me, and I welcome your questions later. Thank you.
Thank you very much, Bernard, for a really thought-provoking and excellent talk. I'm sure there will be many questions after that talk, but if I could just ask delegates to write the questions in the sidebar, and we'll pick them all up at the end of this session, if that's okay. So thank you very much, Bernard, a really excellent talk. So if I could move on now just to introduce our second speaker, Dr. Tony Tam. Tony's a consultant gastroenterologist in the Ulster Hospital in Belfast. He's president of the Irish Association of Gastroenterology and also a member of the governing body, the European Society of Gastroenterology and Endoscopy. He also chairs the Irish National Clinical Programme for Gastroenterology, Hepatology and Clinical Advisory Group. So Tony seems to have many hats and has held many prestigious positions and had numerous publications. So we're very grateful that he's agreed to talk to us today and take part in the WAGE conference. So thank you very much, Tony. If I could hand over to you for the next session on quality improvement initiatives in Northern Ireland. Thank you.
Good afternoon, everyone. Thank you very much for the invitation to speak to this WAGE conference. It is quite an honor for me. So I would like to describe a couple of our quality improvement initiatives in Northern Ireland. And in particular, I would like to focus on the two main initiatives that were tasked by the British Society of Gastroenterology Quality Improvement Programme. It's important to acknowledge that much of the heavy lifting has been done by my colleagues and others, and I am here merely reporting on your results. So I would like to, first of all, define quality improvement. You've heard a lot about this already from Bernard, but I particularly like this definition from Paul Battledon, who is the founding chair of the Institute for Healthcare Improvement. And he defines this as the combined and unceasing efforts of everyone, healthcare professionals, patients and their families, researchers, payers, planners, and educators, in other words, stakeholders, to make the changes that will lead to better patient outcomes, the theme here being health, better system performance, in other words, the care, and better professional development, i.e. learning. So the reason I use this definition is because whenever I go on and talk about our initiatives, especially quality improvement in endoscopy, there is an overlap with service development, and sometimes this can be difficult to disentangle from quality improvement. So the outline of my talk is this. First of all, I will describe our quality initiatives in Northern Ireland in endoscopy. And then I am going to focus on my trust's pilot on the quality framework for what a good gastroenterology service should look like. So first of all, the Northern Ireland quality improvement in endoscopy. And I am grateful to Mike Mitchell, who is a gastroenterology colleague of mine from Belfast and the lead for taking this on and providing me with an update. So let me tell you how it all started. It was in 2018, whenever Colin Rees, who was then BSG Vice President and in endoscopy was setting up a UK-wide QI program and asked if I would be interested in leading the ERCP QI program in Northern Ireland with input from Kofi Opong, who was the national lead. So I organized a meeting with Kofi and all our ERCPs in Northern Ireland, and that launched our endoscopy QI work. And I managed to get a volunteer to lead this, and Mike stepped up to the plate. So the aims of the Northern Ireland Endoscopy QI program are several. First of all, to develop strong collaborative and non-competitive relations between the gastroenterology units in Northern Ireland, to ensure a Northern Ireland presence in GI endoscopy national societies such as the BSG and the Irish Society of Gastroenterology, to maintain a strong endoscopy presence on the Northern Ireland Cancer Network, and to lobby the Health and Social Care Board, HSCB, which will be referred to several times, and it's the equivalent of NHS Wales, for an endoscopy network for Northern Ireland, and to develop a response to the pandemic by endoscopy membership of the Healthcare Board and Department of Health steering groups. So moving on to regional leadership, there are two main endoscopy committees going at the moment. The Regional Endoscopy Steering Group from the Health and Social Care Board, and we have got several gastroenterologists on this committee. And there's also the Care Board's Cancer Reset Cell to try to restart cancer services, and one of our gastroenterologists is in the lead is in this particular committee. So up until recently, Northern Ireland did not have an endoscopy lead, and hence endoscopy was very low on the agenda until waiting lists rose to such prominence and unacceptable levels that the public and the Care Board began to take notice. And the pandemic has again focused more attention as it became clear during the height of the surge that fewer cancers were being diagnosed. But that, of course, didn't mean that they had disappeared, but were just going to be delayed in terms of their presentation. So paradoxically, although initial plans had been dramatically altered by the pandemic, this has actually allowed our endoscopy lead to influence more than he was able to prior to the pandemic. So like a lot of things in endoscopy, we divide the work streams based on the type of scope. So the next few slides will show the outputs. And if we look at the at ERCP, these are the outputs from that work stream. To endorse and implement the latest BSG and ESG guidance, and that's up to the trust to implement. To optimize day case ERCP services with an aim to achieve more than 90% same day discharge, and this is ongoing. To create a hub and spoke arrangements via regional malignant and benign HPV MDMs plus direct communication. So this is ongoing. The Belfast Trust to amalgamate ERCP centers, and this was achieved in 2019. To implement standard reporting for ERCP, and with the National Endoscopy Reporting System, that's going to happen. Create an audit research network, which is ongoing. ERCP teaching courses to involve as many ERCPs as possible. This is ongoing. To provide an advanced endoscopy course in Northern Ireland for trainers. To develop an interface between ERCP and EUS services, which is ongoing. And to introduce an advanced biliary fellowship program in 2021, which is ongoing as well. Moving then on to EUS, the outputs were to develop strong relationship between the Belfast and Craigavon services in terms of standardization, education, and training. to develop local guidelines for the management of Waldorf necrosis, which is near completion, to introduce EUS guided biliary access, and the first such cases have been performed, and there is a prospective database to capture the outcomes. To develop a benign HPB MDM, which was commenced in 2019, but it was paused because of the pandemic, and to introduce an advanced biliary fellowship program, which is ongoing. Moving then on to colonoscopy, the outputs are to ensure at least more than half of colonoscopists have attended training the trainer, which is ongoing, to adhere to JAG accreditation requirements, and each trust is to comply with this, to introduce FIT for colorectal red flag referrals to stratified risk, and to move FIT testing into primary care and bowel cancer screening, and these have been implemented. Implement a straight colonoscopy pathway, and there's a large prospective QI project in Belfast, which was halted during the pandemic. Moving then on to upper GI, the outputs were to develop a teaching forum for early cancer diagnosis, and this is to be arranged, to implement a straight test for OGD and appropriate follow-up, which is part of a large regional QI project, and to assess whether the introduction of Cytosponge can aid Barrett's surveillance, and we're undertaking this in collaboration with Cambridge, and to introduce ESD, and this has been done in the Belfast Trust and the Ulster Hospital. In terms of small bowel and capsule, the outputs were to ensure enough reporting gastroenterologists, a job plan to ensure timely reporting, and to link with National Small Bowel QI Group, and this has been completed. So I'm going to shift gears and move on now to the BSG Quality Framework pilot, and what we in my trust in the Ulster Hospital and Southeastern Trust have done. So just to give you a bit of a background into the quality framework, this is really to try to determine what a good gastroenterology service should look like. And this is based on the perfect patient journey. And with the help of the patient who was on the task group, what they wanted to see from a perfect service was how to get into the system and how they were going to be looked after while in the healthcare system and afterwards. So based on this, we determined the domains of how a patient can get into the service, get diagnosed, get fixed, get out, and get on with life. So these spawned the domains of access to the service, the diagnostics, the interventions, and then re-enablement, ambulatory care and transition. And then after they've been treated, how do we monitor them, put them on the surveillance program? So let me describe our hospital and trust. The Ulster Hospital, which is where I work, is the biggest hospital in our trust, which is made up of 2 other small hospitals. We are a universally teaching hospital, and our catchment population is 450,000, and comprising of rural and an urban population. We have 7.6 whole-time equivalent gastroenterologists in our trust who still do general internal medicine. So what did we do? First of all, we got support from the trust quality improvement lead and team, and we are lucky to have a strong culture of quality improvement in our trust. We set up a multidisciplinary workshop in November 2018, and we invited consultants and the medical team. We invited management, specialist nurses, dietitians, pharmacists, and also colleagues from coding and informatics. So this workshop was organized by our QI team. It took place over one afternoon, and we went over each standard to see whether we can achieve it, how can we achieve it, and is it feasible? So these were our outcomes. We found that several standards were met already, like, for example, access to specialist radiologists and pathologists. There were a few standards like waiting times, which were too hard to do for the moment, and so we parked it. And we looked at the easy wins to keep us motivated and to keep the momentum going. So we came up with work streams and leads, and there were three big themes to the framework: the infrastructure, i.e. describing what we do, our staffing, and how to set up a management structure. So there's a lead for that. There's also a lead for effectiveness, measuring our effectiveness. So for example, in the liver standard, what was the readmission rate? There was a lead for review. So like for example, how do we keep reviews to a minimum and patient self-management? There was a work stream meeting in April 2019, and then a workshop in July 2019. But like a lot of things, this was paused because of the pandemic. So the challenges of our pilot, as we found out, was to maintain the enthusiasm, especially when things were paused during the pandemic. We need time to do this, and so should be in our job plans. All participants need to see the value for doing this, and we need motivated leads. So what are the benefits? Well, teamwork. So, for example, our review lead had set up a group with the nurse and managers to look at how we can get IBD patients to self-manage and have an open review. Motivation and positivity. So this is doing this kind of work is a change from daily negative emails from our trust about trolley waits and long waiting lists. So I think this is something that's doable and positive. Involvement in QI and safety. And so this ticks domain 2 of your appraisal. The culture of continual improvement as well. Realizing that we have to keep moving forward, and also aligning service developments into the quality framework is important. So for example, developing an ambulatory hub is about how to get diagnosed, get fixed, and stay out. And of course, we feel that we are benefiting the patient with what we're doing. So these are the top tips for how to do it if you want to get involved with the quality framework for a good gastroenterology service. And thanks to Bernard and the BSG QI team for helping me come up with this. So the top tips are: get admin support and informatics support from your trust. Identify work streams and leads for each work stream. Undertake a baseline mapping exercise to identify the gaps. Aim to get your consultant colleagues, senior management on board. Involve your trainees and specialist nurses. Use the low-hanging fruit to build momentum. And the basics need to be in place for optimal patient care. And remember that leads can be, for the work streams, can be consultants, but could also be senior trainees or senior nursing staff. So thank you very much for this opportunity, and I'm happy to answer any questions.
Thanks very much, Tony. We do have some questions, but we're going to leave the questions to the end, if that's okay. We're going to have all the speakers together so we can discuss this as a group. So we're going to move on. The next item is from Dr. Andy Yeoman. Most of you will be familiar with Dr. Yeoman. He's, as you know, a hepatologist who works in Royal Gwent in Newport. And he's currently the clinical lead for the Wales Liver Plan. His clinical interests are in the preventative care and early detection of liver disease and its complications. He gave us an overview of the sort of post-COVID work streams and models of working for liver disease in Wales on Monday. This afternoon, he's going to tell us about IQLS, or for those of you that don't know what that means, Improving Quality in Liver Services Programme. So we'll go over to Andy next. Thank you.
I'd like to thank once again the organisers of WAGE for asking me to speak to you today, and this time it's on IQLS and liver services in Wales. So the face of liver disease in Wales has changed over the last 20 years, and this is evidenced by this data from the Welsh Liver Registry that I presented in a different talk the other day. And this shows that whilst alcohol has remained a relatively static cause of liver disease in Wales in the last 20 years, NAFL has increased by nearly tenfold. This has been mirrored by a significant increase of between 2- and 3-fold in the incidence of cirrhosis, portal hypertension, decompensation, and liver cancer. So the Welsh context around liver disease care in Wales is very much around the Liver Disease Implementation Group, which launched in 2015 as an attempt to try and improve the recognition and management of liver disease across the whole of Wales, but has obviously been impacted by COVID, as I talked about on Monday. We can't ignore the workforce situation in terms of its implications for provision of liver services and how that impacts service review and redesign in the context of a post-COVID world. So in terms of workforce and capacity in Wales, I think if you think back to about 10 years ago, Mark Hudson at Basel did a survey and they found there were less than 4 whole-time equivalent hepatologists in Wales. Now, it depends on how you define whole-time equivalent hepatologist, but if you consider that as somebody who spends more than 50% of their working time in hepatology, there are now 16 consultants across Wales that would meet that description. However, there's quite significant inequality in the distribution of these across Wales, and these reflect often sometimes historical challenges in recruitment, particularly more rural areas. So you'll see that Powys obviously has no acute hospitals, so it doesn't have any, but North Wales and West Wales are currently poorly served, whereas the Southeast, where albeit has the bulk of the population of Wales, but there's a significant dominance of the hepatology workforce in the southeast of the country. Wales has historically been better staffed than England for CNSs as a result of the Bloodborne Virus Action Plan, but we're still some short away of what Scotland are offering in terms of specialist nursing support. But I think there's still some more work that can be done there, particularly in areas where it's difficult to recruit consultants. In terms of capacity to provide good quality care in Wales, we've got the imminent National Liver Function Test or liver blood test pathway. And this will help with the recognition of serious disease in community settings and will probably engender an increase in demand for secondary care services, but might actually offset some of that by preventing a lot of referrals from primary care with blandly abnormal liver tests. We're also well blessed for FibroScans in Wales, which is why the National Liver Blood Test pathway is a real opportunity to improve liver disease care. We have the best FibroScan coverage in the UK and probably Western Europe based on the number of scanners per 100,000 population. At the moment, however, I don't we utilise our FibroScans as well as we might, and that's probably due to the staffing base we have to be able to take the scanners around sometimes very remote rural areas. But that's an opportunity for us in the future. So to talk about improving quality in liver services, or IQLS, so this was a scheme launched in July 2017, led initially and still so by James Ferguson, who was a consultant hepatologist in Birmingham. It was backed by Basel and the BSG and has strong patient support group involvement from the very beginning. It's in essence, it's a quality improvement program through accreditation. So it's the JAG version for liver disease. And at present, there are 60 services across the UK signed up, and all of the Welsh Health Boards are currently signed up to this scheme. So a brief declaration at the beginning of this year, I was appointed as the National Quality Assurance Lead for IQLS. So I have to just declare that when I'm talking about IQLS. So why accreditation, and how is that going to help us with our liver service development across Wales? Well, I think the important first thing to say is that just observing somebody coming in to observe what you do is not a panacea. In fact, there's very little evidence that actually observation or inspection per se drives up standards. And that's mainly because people too often look at those things as a single event rather than a process. So the IQLS process or scheme is very much a process of continual improvement rather than a single event based on a one-off assessment or one-off data dump of evidence to the central group to review. So it's very much about taking your existing service and growing it over a period of time to just make the whole service better. It's not about passing or failing, but it's about getting better. It's about making continuous small improvements towards a better, more patient-centered delivered service. The other way the scheme is useful is that it provides a framework supportive approach rather than a heavy-handed didactic negative approach. So IQLS, like all these accreditation schemes, will have standards, and these are the 6 standards within IQLS. There's leadership and operational delivery. Patient-centered care is very much a strong focus of it. There needs to be a strong attention to risk and patient safety and strategies to mitigate those. Review of clinical effectiveness so we can benchmark. A review of workforce to meet the demands of the local population, and what systems are in place to support that service delivery, design and redesign. I'll just highlight some of the standards to meet what's called level 1 accreditation within the IQLS, which is sort of halfway towards the level 2, which is a complete accredited service. So level 1, I think the most high level of the level 1 priorities is that the service has an annual operating plan. And that's really about having measurable objectives with key performance indicators for the service for that coming year. So setting out a strategy rather than just saying, oh, well, let's just reduce waiting times. How does that fit into the whole of the service? So to do that, you need to map it out. And that's what a service organogram is, to really map out your service so that also patients can navigate it. You need to identify what the roles and responsibilities of each of the staff within the service. What are the plans specifically for service development based on your local needs analysis? How do you plan for disease prevention strategies, and early recognition of liver disease is a strong part of that. And that tallies very nicely with the National Liver Blood Test pathway in Wales, for example. What are your training and workforce development needs? And what other pathways do you need to run an effective service? For level 2, in this sort of patient-centered care, I think a really important part of that is to have an annual formal survey. We don't often ask our patients in detail exactly whether the service we provide them is any good or not, and how can we use that feedback to refine and improve the service that we provide. I know in Gwent, when we went through the IQLS assessment process, we set up a patient support group. And actually, as a result of that, we took on the strategy of you said, we did. So patients often found it difficult to be able to navigate the system, and the GP would often delegate any responsibility for any healthcare to the secondary care team, and then difficulty getting hold of consultants. So we set up a nursing advice service, and that's proven very, very popular. So these are the things that can be done quite simply sometimes to improve the patient experience. To the standard 3, it's about setting and monitoring safety improvement targets. So that may be MRSA rates, for example, it may be falls, readmissions. And this is about really developing a performance dashboard. We hope to be able to utilize the Wales Liver Registry to somewhat inform that across Wales. So there's not that we reduce that duplication of effort, if you will, across the whole of Wales. But certainly we need to be able to develop a set of metrics that are important to record, like readmission rates, 30-day mortality, the number of procedures that are done as day case paracentesis, for example, versus the total number of acidic drains done. These are good metrics of how you're providing a high quality liver service. For the 4th domain, it's about monitoring clinical performance, and this is largely around audits. So people who are familiar with JAG will be familiar with completing audits as part of this. And the main ones in relation to IQLS are antibiotic prescription in acute variceal bleeding, acidic tap in emergency admissions with ascites, albumin and antibiotics in patients diagnosed with SPP, and the percentage of admissions with decompensated disease seen by a gastroenterologist, hepatologist within 24 hours of admission. And now finally, the percentage of outpatient paracentesis carried out in an ambulatory or intermediate care setting. Now, most of those you'll be familiar if you've seen the Basel Care Bundle, because the first 4 of those quality metrics are all incorporated under that care bundle. So just incorporating that and auditing that will give you a lot of the data you need to identify where the gaps are in that emergency care when patients are admitted to hospital. And that's a good surrogate for the total quality of care across your entire service. So in terms of iQuils in Wales, as I said, the 6 health boards are signed up via the LDIG, so the membership of and the clinical lead session helps support the development of the service to meet the iQuils requirement has been paid for by the LDIG, and that will need to be renewed at some point in the next 12 months that we're currently looking at within LDIG. To date, 2 health boards have had peer review visits. That was Cardiff and Vale and Aneurin Bevan. This was very early on in the scheme, when even prior to level 1 accreditation services were receiving site visits. That's not going to be the norm from now on, because there's now 60 sites registered across the whole of the UK, and the accreditation team isn't big enough to be able to do that at this point in time. At the moment, Aneurin Bevan is the only level 1 accredited service in Wales, and one of only 8 in the whole of the UK. I know Cardiff and Vale are making good progress towards that. And there's 2 further health boards, namely Swansea Bay and Cwmtaf Morgannwg, who are awaiting assessment of the level 1 standards. And the remaining 2 health boards continue to work towards level 1, and we're trying to support them to do that. If you look at the map of the whole of the UK, you'll see that Wales is actually performing quite well within this. You can see the density of the sites within Wales compared to the UK as a whole. There's no sites from Scotland currently registered, and only 1 in Northern Ireland. So I think we're really trying to sort of lead the way on this by having all our health boards involved in the scheme. And it's not, as I say, necessarily about passing or failing an assessment or a process. It's about making continuous improvements, and being part of it and being part of the scheme will lead to improvements whether somebody never actually reaches level 1 or not, although that is obviously the aspiration for all centres in Wales, and eventually level 2. So what are the key considerations when adopting iQuils or working towards the accreditation standards? Well, the first thing is to set up a local team. So that requires a local clinical lead and a nursing lead. You do need a strong managerial lead, which will normally be a directorate manager. And junior doctor representation is now a new thing in there, because it's recognised that the quality of the training experience is a good surrogate for the quality of the whole system care. It's really important to set up a working group with monthly liver business meetings. They don't need to be long, 30 to 45 minutes is usually enough, sometimes an hour if you've got lots to discuss, but they don't need to be too detailed, but you need rolling agenda items so you can make progress against the standards as they exist and work on them sequentially. A yearly away day, well, we used to be able to do that before COVID, but that's certainly something that as we emerge from this COVID second wave would be something that is a very useful way of putting it all together and having dedicated time away as a broader group, rather than perhaps a smaller group just working on the iQuils as based on the team above. A patient support group or link with one that's run by the British Liver Trust is really important to start to generate that patient level feedback, because otherwise without that you can't really push on some of those patient level metrics that need to be met to get level 1 accreditation. So the ultimate question is, how does being part of this deliver better care? And I think for me, the main reasons it does, and the main reason I was keen to continue to work with the scheme is that I think the framework, having gone through assessment, is that it very much encourages joined up thinking. So most of us have really good aspects of our care and some not so good aspects of our care, and that applies to all health boards across Wales and all trusts across the whole of the UK. So it's about thinking about how do the different disparate parts of your service link in together and become a coherent whole, so people don't have good care in one part of it, but poor care in another part. It most certainly promotes person-centered care. And I think really the annual plan is very helpful in setting meaningful goals and crucially achievable goals in the next 12 months. So it hasn't got to be the finished article, but set something that you can achieve within a 12-month period. Certainly, I can vouch for it. It leads to increased management buy-in. Liver disease doesn't have huge priority within health board services, and this is one of the reasons we struggle to boost our alcohol care teams, for example. But certainly, the carrot of accreditation by an RCP-run system is a draw, and it's a sort of a badge for the organisation. But it also shows that as a service, you're serious about getting better and making serious improvements, and that meets other national strategies like a Healthier Wales. The other advantage is it's an opportunity to learn from others. We learned a huge amount from our site visit, and I learn a huge amount when I speak to other people involved in the scheme, or when I'm looking at other people's assessment data. So you get to see good exemplars of practice across the whole of the UK by being part of the scheme. And there's a best practice information repository as part of the iQuils system that people can look at for how people do ambulatory care well, how people do daycare procedures well, for example. And importantly, it allows us to benchmark ourselves against the very best and the highest standards of care that's on offer. So how can Welsh Services meet this challenge? Well, I think this is about building off the back of the work of the Liver Disease Implementation Group. Really, this is bringing all the different strands of early detection, prevention, high quality inpatient care, helping people live with their liver disease. All the major themes within the liver disease strategy for Wales actually can be brought together under this IQLS framework. The National Liver Blood Test pathway to improve increase the detection of serious liver disease will also help us meet some of these priorities around the IQLS, around that preventive aspect and having good quality pathways. And we can use the Wales Liver Registry data that I talked about on Monday to deliver a data-driven workforce needs analysis. Now, within the IQLS is this information repository, but we can share, possibly via wage, best practice business cases, job descriptions that are a little bit more specific to Wales than would otherwise be the case for the UK-wide IQLS approach. And that would be a good opportunity of doing things once for Wales. We're all employed by the NHS in Wales, so we shouldn't be duplicating effort in terms of job descriptions, standard operating procedures, etc., etc. We should be sharing these widely so that people are not having to duplicate that work. We as a community in Wales are still relatively small. There are 16 consultants now who spend most of their time working in hepatology, and we can agree some national service standards on cirrhosis management, rare disease care, and national audits of practice to make sure that we're benchmarking internally as well as externally. And we can look to develop regional networks. So if some health boards don't provide certain services, such as complex hepatobiliary endoscopy like Spyglass, TIP services, and super specialist advice, if you haven't got somebody with a particular interest in complex autoimmune disease, for example, how do we plug each other into these sorts of regional networks within Wales? And for me, this is about consistency, collaboration, and innovation. So the consistency is around national pathways, not just for abnormal liver blood tests, but for fatty liver disease, for other aspects of recognition, cirrhosis care, and developing national care standards around those. Collaboration with each other to share best practice, data, business cases, and to support one another to get to where we need to be. And to collaborate with other services. So that might be the future development of community diagnostic hubs or hematology or dermatology, where patients often pitch up with their liver disease on methotrexate, for example. How do we link in with those other services to try and recognize liver disease and provide high quality care? And then finally, in relation to innovation, it's development of ongoing novel pathways. But should we be more innovative? Should we think about shared job plans if some areas can't recruit and other areas can? Could we look at, like ICU are currently doing, where people have job plans across different health boards where they spend certain sessions doing complex autoimmune clinics or complex cirrhosis care clinics or transplant step-down clinics, something of that nature. We need to be innovative in the approach we take in this post-COVID world. So in summary, I think the rising incidence of liver disease in Wales and the challenges of COVID clearly equate to me that more of the same just isn't going to work. It's not going to cut it. But we do have some natural advantages in Wales as a small nation. We have good quality IT with a Welsh Clinical Portal. We've got a liver registry data that will give us good information on the demand on our services, and we can try and use that data to refine the workforce structures that we have and to inform those. This, however, does require a structure to pull all these different strands together. And I think certainly from our involvement, I believe that IQLS fills that gap. So thank you for listening, and I'd be happy to answer any questions.
Muted, Joe. You're on mute.
Sorry about that. Am I okay to go now? Thank you very much, Andy. Sorry for the technical hitch. Again, any questions, please can you put them in the questions bar for Andy, and we can get into addressing at the end. But great talk, thank you. So we're going to move on now to Dr. Beverly Oates. She's been name checked a couple of times already this afternoon, so I feel like I know her already. Beverly is a consultant gastroenterologist in the Wirral, who completed a specialist training in the Mersey region. She's been heavily involved in training to date. She was a TPD for gastroenterology in Merseyside and on National Recruitment League for gastroenterology. More recently, she's on the BSG training committee. And she's now been made clinical lead for the gastroenterology work stream for GERT, getting it right first time. I think there's a lot that we can learn from that. And she's going to talk to us about that now.
Thank you so much for giving me the opportunity to talk to you about the Getting It Right First Time, or GIRFT, programme in gastroenterology. So I'm going to split this into two areas. So initially, just talk to you about the background to GIRFT, as I appreciate this is an NHS England programme rather than the Four Nations, sadly, so you may want some more background. But then concentrating on the gastro GIRFT side of things, so really a whistle-stop tour for you of how I've designed and developed the data packs and the questionnaire, how I've done the deep dive visits, give you some examples of the kind of metrics that I've used and the variation seen, and then where I'm up to now with gastro GIRFT with a summary and conclusions. So it began in 2012 with an orthopaedic surgeon called Tim Briggs. He worked in a tertiary referral centre and was conscious when things went wrong for patients, such as an infected hip joint. It was awful for patients, but also very expensive healthcare, and seemed to happen at a different rate in different hospitals. So he wasn't sure why some hospitals perhaps had a higher infection rate than others. So he managed to get a £200,000 pilot study project fund from the Department of Health and NHS England to look at patient care and outcomes in orthopaedics. And he looked at the data that was available so that he could benchmark trusts to show them things like their infection rates and outcome rates in orthopaedics. And he did peer visits where he visited all the centres in England that did orthopaedics, so 144 trusts, which span 220 hospitals, showing them their data and making them see where there may be some unwarranted variation that they could adjust, but also identifying areas of good practice. Following this, he wrote a national report, and it was in that report that he first used the term Getting It Right First Time, that later became the name of the programme and its mission statement. He then did a refresh of the data and a further national report 2 years later, where it seemed that this had saved in the region of about £50 million for orthopaedics, particularly with things like reducing length of stay, adjustments in practice, such as using more cemented hips in the over 65s compared to previously the range was between 5% in some trusts and 95% in other trusts of using cemented hips in the over 65s, with an average of less than 40%. And yet it was felt cemented hips were cheaper than uncemented ones, and actually really good outcomes as well. So that change in practice saved 4.4 million. There was a reduction in litigation, and orthopaedics was only second to obs and gynae in terms of litigation costs for a specialty. So 36% reduction in litigation saved a lot of money for the NHS, but also in better procurement. So many trusts discovered they weren't getting as good a deal as they thought on the metalwork they were buying for hips and knees. So overall, what started out really as a quality improvement project really ended up being both a quality improvement and a cost improvement programme. So not surprisingly, with that kind of return on this kind of investment, it was looked at, was this methodology transferable to other specialties? And the methodology is quite straightforward. There's 3 bits to it: an analytics phase, a review phase, and an implementation phase. So in the analytics phase, it's looking at what national data sets are there, looking at the sort of priorities for a specialty, harvesting the data and developing a data pack that can then be sent out to all trusts. The review phase is what's become known as the deep dive visit, so that peer-to-peer clinical lead visit to a trust to help them look at their data, to interpret their data and make recommendations and a kind of implementation plan of how they might be able to make some changes. And also the clinical leads will write a national report looking at those kind of recommendations. But I think just as important, this implementation phase is to allow those kind of lessons learned to be transitioned into business as usual, rather than just be a report on the shelf. And I think that's where this becomes really a very exciting project. So with the help of a £60 million investment by the Department of Health in November 2016, this programme was rolled out first to a number of surgical specialties, and then into medical specialties more recently. And there's now over 40 clinical work streams in GIRFT and more than 1,000 deep dive visits across England each year. There's over 60 clinical leads and senior advisors in post. So some specialties have 2 leads, co-leads, or they may have a lead and a senior advisor. In gastro, it's just me as a clinical lead. So what kind of support is there? Well, there's a lot of information on the Getting It Right First Time website. There's now over 40 clinical leads, and we have a project manager assigned to us to help us deliver our work stream. So as a clinical lead, I cover all gastroenterology within England, so all the centres in England for one specialty, whereas there's also a regional approach where the country is split into 7 regions, and in each region there's a hub. They'll have clinical ambassadors, at least 2 in each region when this was set up, and implementation teams. So the regional teams cover all specialties in one region, whereas the national clinical lead covers all their specialty, but across the country rather than a regional approach. I was quite lucky in the Northwest in that 2 of the clinical ambassadors in the Northwest were gastroenterologists. So Neil Haslam, who specialises in endoscopy, and Paul Richardson, who specialises in hepatology. I'm a luminal gastroenterologist, so that sort of gave me a reasonable, most bases covered really by being able to pick their brains as well. And then locally, each trust board should have a sort of board level champion for GIRFT, so that there is somebody linked into each trust that the ambassadors and the regional teams are liaising with. So how did I go about developing the Gastro Data Pack? I was conscious that really to improve performance, you need good outcome measures. So looking at what data's out there that we could benchmark from. And I felt that maybe some of the outcomes in surgery may be a bit more obvious in those kind of metrics like infection rates or return to surgery rates or mortality or length of stay. But gastro is a multi-organ medical and interventional specialty. I think, particularly with chronic conditions as well, it's a bit harder to get those kind of endpoints. But looking at all the subspecialty areas as well, we can't cover everything in a 2-hour deep dive visit. So I had to kind of look at representative metrics that would span each of the subspecialty areas as a kind of barometer of service. And I liaised with various subspecialty colleagues across the country and various stakeholders, trying to sort of canvass opinion of what people thought might be good to show in this kind of data pack. So just to show you some examples, in endoscopy, I know there's good data in things like the National Endoscopy Database, and in Trust's endoscopy reporting software is usually quite accurate. But I looked at things like age of people scoped, sex and day of the week as a kind of surrogate marker for capacity and demand issues. And I'll show you some of that data. I looked at GI bleeds, particularly for banding of esophageal varices, looking at how much was done as a day case versus emergency bleeds as a surrogate marker for how proactive an endoscopy unit or a gastroenterology hepatology service was at perhaps screening those patients at risk of varices, of completing banding programs where appropriate in those patients that have had previous bleeding or at risk of bleeds, to try and reduce emergency presentations of GI bleeding with varices. I know it was mentioned in your wage conference on Monday, talk about day case acidic drains. Certainly, if you leave patients to present with recurrent ascites, they're often in hospital for a number of days for each admission. Whereas if you're more proactive at managing patients with day case paracentesis, you can reduce length of stay, reduce hospital admissions, reduce complications. For luminal, I found it was a bit more difficult in that quite a bit of our work is done via clinics, and clinic national data sets for things like HES, hospital episode statistics, are pretty poor. The best you can usually say is somebody's been seen as a new patient or a follow-up, and whether they've been discharged at first admission. You can't generally say much about what they came to clinic with or what they left with in terms of a plan. So I was mainly looking at day case or emergency admissions. And I looked at with inflammatory bowel disease, what percentage of patients being admitted with IBD came in as emergency rather than elective planned, endoscopy or infusion of biologic, that kind of thing. Again, as a marker of how proactive a service might be at reducing emergency admissions. So earlier diagnosis initially, better, quicker management of flares, better escalation of treatment when needed to try and reduce emergency admissions. With nutrition, I wanted to look at line infection rates. And again, looking in HES data, it becomes apparent it's not very easy to get that kind of data how we would need it. I'm sure you're aware that with line infection rates, we should be looking at what number of line infections per 1,000 days of line use, but you can't get that out of HES. And equally, you only get into HES or did if you're on TPN for 14 days or more, or you were admitted on it, so you're already home funded. So again, it became apparent as I was looking at all the kind of data out there that some things we'd want to be in the data pack is hard to get accurate data, national data sets from. That's where the gastro questionnaire comes in. So with GIRF, they often get you to send questionnaires out to all the trusts so that we can also gather data that's not available in national data sets. It does allow you to kind of set the scene for the visit, to sense check the data that we've got and help me interpret the data packs. We do collect all the questionnaires in well before we start the visits. So actually that was really useful for us because this was all pre-pandemic. You want to be able to compare the data at that sort of the same kind of time point, and the visits may take 18 months or more to complete. So we wanted to collect those all in at the beginning. So these are all pre-pandemic, the data we got from those. I put it into the sort of Excel spreadsheets with different tabs so that each of the centres could get the relevant person to fill in the subspecialty tab and list all the kind of data bits that we were trying to capture, like a bit about workforce and networks and rotas and number of endoscopy rooms and what their kind of services were made up of so that we could really sense check the data. I did put in about research, mainly because it is clear that some centres that are more research active often have better clinical outcomes, and trying to sort of correlate that by capturing a bit of information about research and making sure it was given a priority. And I also put in the questionnaire about getting the trusts to tell me their sort of top 5 successes and challenges and their potential solutions to their challenges, really to help focus their mind and mine to look at areas that they were doing well on, that I might be able to pinch ideas from, or areas they were struggling with that I may be able to help with. So in terms of the visits, we started off, I did 3 pilot visits. So these are the green peas on here, down in Torbay, where the BSG president was at the time, and a regional centre, a neighbouring centre to me, and also up in the Lake District. So again, to make sure I'd sort of span the country reasonably far. They were really helpful, those centres, testing the data pack in the visit and giving me feedback so that I could adapt that before I then set the data as it was, and all the rest of the visits were done with that data pack. So the light green are all face-to-face visits. So it was a bit like the old 1987 Steve Martin and John Candy film of sort of trains, planes and automobiles, really, of dashing around the country, and a ferry to get me to the Isle of Wight. But visiting these centres to do a quick look around the centre, a 2-hour deep dive visit, and go with and helping interpret the data with them. Then the pandemic hit. So there was about 3 months where we couldn't do any visits. That actually gave me an opportunity to catch up some of the site reports and to start writing the national report, because really by the time you've done about 40 visits, you can really get a feel for some of the themes that you'll want to pull into a national report. But by June, as lockdown eased, I was able to change the format and complete all the rest of the visits in a virtual MS Teams format, which was much better, in terms of lower carbon footprint, but also more time efficient. And it did allow us to record the visits on Microsoft Teams so that actually the centres could have a copy of that to refer back to. So that meant I was able to write the reports more efficiently, and it could be a little bit briefer, the report that we gave them, and we gave them that report on the day. So we'd write it straight after the visit and get it back to them. So I'm just going to show you a bit of the data. So for those that aren't used to looking at funnel plots, a lot of the data we showed as funnel plots where all the centres in England are a dot, but the centre you were visiting would be a diamond, so you could see clearly where that particular centre was. Obviously, I've taken those off for the national report and for doing presentations like this. So you'd have a funnel plot where the red line in the middle here is the mean or average. You then have 2 and 3 standard deviations above and 2 and 3 standard deviations below. So if your centre was 3 standard deviations above or below, the chance of being there by chance is 2 in 1,000. If you're between 2 and 3 standard deviations, the chance of being there by chance is 5%. So often it's worth exploring with these areas why they might be struggling in a metric perhaps, or down here, what they're doing well that we can pinch ideas from. By definition, most centres will be in the average. We don't come to work to be average, so we'd still explore with these centres about, how could they be exemplary to get more ideas from them. So this is looking at emergency banding of varices. So to give me an idea of how much of banding was being done as an emergency rather than the more sort of proactive elective care. And I do other metrics as well following this through to look at numbers of GI bleed admissions, mortality figures, that kind of thing, to sort of see whether these centres do have better outcomes. This is just looking at day case paracentesis rates. So again, this is in the national report, but just showing the huge variation between what percentage of paracentesis in centres was being done electively as day case versus allowing people to mainly come in as emergencies. And this certainly increases length of stay, recurrent readmissions, that kind of thing. This was looking at IBD patients as an emergency, again, showing the huge variation that we have. And I did follow this through as well, looking at readmissions, looking at colectomy rates, looking at acute severe colitis admissions, that kind of thing. And again, to try and support trusts where they may be struggling at identifying to trusts about the provision that's needed to have, good access to clinics, to have specialist nurse inputs and helpline and flare clinics, that kind of thing. And that some trusts where they may say, we don't have the money for a specialist nurse, and you could point out that actually you're spending far more by having recurrent emergency admissions. This is just looking at some of the endoscopy data. So I looked at gastroscopies in younger patients, mainly because it was felt that we do probably far too many normal gastroscopies or gastroscopies for patients where it's not a change in their management, particularly where they don't perhaps meet NICE guidance. They've not had a test and treat approach for Helicobacter or a trial of treatment for reflux. So I looked at what proportion of gastroscopies in a centre were being done in younger patients. In the data pack, I'd have information about the population that they serve, so some trust level metrics at the beginning, so that you could tell perhaps, are these centres serving a younger population? Is that part of the argument? Or really are some centres just not as good at vetting their endoscopies being referred in? This became much more apparent post-COVID, and I know with the senior clinical triage that was recommended and all the endoscopy that stopped, open access gastroscopy predominantly stopped, it became much more apparent how much of the sort of open access gastroscopy or younger patients' gastroscopies perhaps don't meet NICE guidance and don't need doing. This is just a bit more data. This is looking at flexible sigmoidoscopy. So this is women on the left, men on the right, and the England average is the black line. This centre does bowel scope screening, or did. So again, that's why a much higher proportion of their endoscopy for FlexiSig was done in this age bracket, 50 to 59. So I could explore with the trust, is it outstripping your ability to provide flexible sigmoidoscopy to other age groups? So have you got sufficient capacity for this service? but also post-pandemic, being able to sort of say to centres, you know, what's your plan for this workforce? If you have endoscopists that are only bowel scope trained, you need to prioritise getting them trained in other modalities like colonoscopy or gastroscopy, or you may lose that workforce. This is a surrogate at looking at 7-day endoscopy. So it's a surrogate because in HES, you really can only find date of admission for the endoscopy rather than date of test. But the majority of endoscopy is day case. So date of admission is date of test. So this centre, this is the same centre for the two graphs, showing the blue dots here are the England average, and then the days of the week where the procedure was done. So this is showing this centre did bowel scope screening on Monday, Wednesday and Thursday, so hence their peaks here. But what was more noticeable for them was they're doing a huge amount of colonoscopy at a weekend. And I was pointing out to trusts boards that, you know, if this was an airline, Monday to Friday cheap seats, Saturday's business class, Sunday's first class, in terms of cost of putting the service on. And often the tariff in England will be the same, whether you're scoped on a Tuesday afternoon by a nurse or whether you're scoped on a Saturday by a premium rate endoscopist on waiting list initiative or insourced. And again, also talking to trusts about the difference between 7-day working and 7-day service, because many trusts, what's happening is this is 7-day working, where people are doing overtime at weekends to try and help with the capacity. Whereas actually what you really want to run is a 7-day service, whereby if you're working at a weekend, you'll have a rest day in the week, because this is burning out your workforce as well. This is just looking at endoscopy. This data came from doing the GIRF questionnaire, so asking trusts how many endoscopy rooms they had and looking at the total number of endoscopy, GI endoscopy procedures. Again, they reported from their endoscopy reporting software. So interestingly, you could see the variation in that perhaps if you look at this trust here with 5 endoscopy rooms doing 20,000 GI endoscopies a year, compared to say this one that has 10 endoscopy rooms and again doing similar numbers to somebody with half the number of rooms. This doesn't take into account the complexity of procedures. So maybe this service is doing more, you know, ERCP or, you know, complex polypectomies. And maybe this does a lot more gastroscopies or bowel scope flexi screening, things like that. But again, it helped to have conversations with trusts about things like how good they were at backfilling endoscopy lists, about flexible working, also trying to get them to see if they were doing a lot of non-GI endoscopies in a unit. So some units may have a lot of rooms, but have other procedures going on like cystoscopy or bronchoscopy, and having got conversations about how to increase capacity and could we move some of the other services out of endoscopy and have a GI endoscopy unit to deliver the capacity that we need. So where am I up to? I've done all 129 visits. I've written all the site reports and I've written the national report. It's still embargoed. It's been in a queue waiting for national sign off for about 6 months now. I have at least now managed to get them to allow people to get access to the embargoed report through the GIRF website, the best practice library. You can register if you've got an NHS email address to get into the best practice library and see these embargoed reports. And trust boards have been sent in England the links to show that they can see embargoed reports now. The report has 24 recommendations in with about 75 actions. It's got a chapter in about how COVID's affected our specialty and looking at all those recommendations in the context of COVID, showing that actually they all still valid and some are even more important than ever in the post-COVID era of recovery. The trusts can get their data from, we put for the visits, their packs, the visit report and the recording, if it was a virtual visit, onto Future NHS website. And also we've been working on putting refresh data into Model Hospital or Model Health website. So again, trusts can see more up-to-date data. So in summary, GIRF's a clinically led program. It's by frontline clinicians. It's a sort of peer-to-peer approach. Hopefully we've got some credibility as we're still working on the front line, so the clinicians that they've picked as clinical leads. It's informed by data analysis across a whole broad range of metrics to give you a sort of deeper insight into performance and help explore solutions. It's not like perhaps JAG or CQC where you may have a sort of pass-fail or requires improvement. It's literally there just to help. So we look at where people are doing well, can we get ideas from them and disseminate them around the country? And where trusts are struggling, can we give them links and support and link them in with other trusts that are doing well in that area? So it's to help reduce unwarranted variation to improve patient outcomes and give them support to implement those kind of plans into business as usual. So a shoulder to shoulder ethos with teams working together, trusts linking together with networks and across nations, hopefully in the end, for better, safer patient care and better use of resources. So I think it really is a definite win-win if we can have a kind of holy grail of medicine that you can provide better care to patients at a cheaper rate, which allows you to then reinvest that money into ongoing better care for patients. So thank you very much, and I'm happy to take any questions.
Well, thank you very much, Bradley. That is a lot of work and a lot of hours on Microsoft Teams. You must be an expert on it by now. Right, we're going to move on to, we've got lots of questions coming in, that's brilliant. We're going to cover them all at the end. Our last presentation this afternoon is from Mr. Mark Coleman, who's a surgeon. He's a colorectal surgeon based in Plymouth. He specialises in laparoscopic surgery, so much so that he's basically taught all of the other surgeons in the UK how to do it. So over to Mark, thank you.
Good afternoon, everybody in Wales. I'm going to talk about quality assurance in surgery, and thanks very much for the very kind invitation to present at this meeting of the Welsh Association for Gastroenterology and Endoscopy. I am a consultant surgeon at universities, hospitals in Plymouth in England, and chairman of JAG, and you'll see on my slides there, I was also national clinical lead for LAPCO, which was the national training program for laparoscopic colorectal surgery in England between 2008 and 2014. So what is quality in surgery? Well, for me, it's all about competence. So what is competence? I think for starters, it is the performance of the right operation with no uncorrected consequential error, with reasonable efficiency, and for the trainees in the absence of trainer input. These for me encapsulate quality in surgery. Let me take you on a 30-year journey. In the last century, open surgery was the gold standard. Outcomes were determined by postoperative morbidity and mortality. Surgical training was a nepotistic apprenticeship in which progress and promotion were determined by word of mouth and logbooks. By the time of the new millennium, we entered an era of rapid technological advances exemplified by image-based surgery and competence-based training accompanied by an ongoing increase in public awareness of quality and outcomes in surgery. Uncontrolled expansion of laparoscopic surgery took place through the 90s, accompanied by reports of adverse outcomes such as common bile duct injury and colorectal cancer port site metastases. In the noughties, this led to professional bodies in Europe and North America issuing guidelines and regulations to slow and/or prevent the uncontrolled adoption of laparoscopic surgery in general and colorectal surgery in particular in the absence of adequate evidence and expertise. In order to paint a picture of how we now consider quality assurance, I'm going to use an example very close to my heart. 14 years ago, I led an NHS England funded training programme for colorectal consultants to convert from open to laparoscopic colorectal surgery. This was the landscape we were in at the start of LAPCO, the National Training Programme. The uptake of laparoscopic colorectal surgery, as you can see, was low. And the self-taught learning curve was long, around 150 cases, during which time it was attended by poor outcomes, morbidity, high conversion rates to open, and long operating times. To remind you, at the same time in the UK, unlike many developed countries, we already had heavily regulated system governing the management of colorectal cancer, including subspecialization of surgeons and other specialists, multidisciplinary teams, and peer review. What led to the LAPCO programme was the NICE guidance reissued in 2006 to say that laparoscopic colorectal surgery should be offered to suitable patients by appropriately trained surgeons. This raised numerous questions at the start. How do we train several hundred open colorectal surgeons to transfer their skills to laparoscopic surgery safely, and will they want to be trained? Who will provide training, and how do we verify the skills of trainers? How many cases will be required to gain proficiency? How do we objectively monitor the progress of training or formative assessment? Will good clinical outcomes be maintained during a process where surgeons are ascending their learning curve? Is the process of training cost effective to the NHS? Will quality of laparoscopic colorectal surgery be maintained long-term by surgeons who have passed through the programme? At the start, the National Cancer Action Team at NHS England, led by Professor Sir Mike Richards, prompted by several key opinion leaders, agreed to fund the so-called Pilot National Training Programme for 1 year to initiate a process and explore these issues. Through most of 2008, little or no training took place until a change of leadership, and Jared Torkington from Wales was one of the people that interviewed us, and I became the leader of the programme late in 2008. And we decided early on to restructure the programme, to amalgamate the research and training steering groups, and to agree some basic answers to the questions I have outlined above. We appointed 67 laparoscopic colorectal trainers in a network of 11 training centres based in around 35 different hospital trusts. We allowed outreach of trainers, in-reach of trainees, and immersion models of training through a flexible, trainee-friendly network. The only rule was hands-on training, as in the trainee does the procedure with the support from his or her trainer. We used a Delphi process to guide the development of both formative and summative assessment tools. This is the formative global assessment surgical training form, and we asked the trainers and trainees both to fill out these forms online, and we linked the funding of trainers to the completion of such forms. We put all of our trainers through a bespoke 2-day Train the Trainers course, many of which you will be familiar with, based on the Train the Colonoscopy Trainers course to elevate and standardize their skills as trainers. And I'll dwell on this a little bit if you'll indulge me. We developed systems to test the impact of the course. And we use the Delphi process to design a GRS for surgical trainers called the STAR form, or Surgical Trainee Trainer Assessment Report. We applied this using Kirkpatrick's levels of course evaluation. Reaction, or did the course delegates like the course? Learning, did they learn anything? Number 3, did they transfer the course into their practice? And did it result in improvements in income? Some of you will be familiar with this. Apart from the expected positive reaction, or level 1 Kirkpatrick, delegates on the course exhibited significant changes in capability as trainers before and after the course, or level 2. This change was transferred into their practice, we send STAR forms to their trainees, and we ask them to fill them out before and after the trainer had been on the course. Finally, the change was transferred into their practice through level 4, and participation on a course helped to shorten the proficiency gain curve for our LabCode trainers training their own trainees. We also monitored clinical outcomes and linked these data to the educational assessment to ensure training was not accompanied by poor outcomes. We identified, through analysis of our GAS forms, our formative assessment system, that 15 to 25 cases were typically required to achieve competence, though some cases were harder than others. You can see here, for example, elements of the procedure like pelvic dissection are more tricky to learn than, say, exposure, setup and dissection of the vascular pedicle. Our passing out test or summative assessment test, LCAT, a video-based tool, set the bar high, and less than 70% of consultant trainees passed at the first attempt. Those who failed were provided with detailed feedback and opportunities for repeat assessment and/or retraining. Health economic analysis showed that the programme theoretically saved the English taxpayer nearly £12 million through the avoidance of complications. Finally, long-term analysis suggests that laparoscopic colorectal surgeons who have participated in LabCo continue to demonstrate superior outcomes compared to peers who have trained through other means. Many of the outcomes I've presented today have already been published, and I want to dwell on the clinical long-term outcomes, which were only published late in 2020. Using HES data, we looked at the clinical outcomes from elective colorectal cancer resection of LabCo trained surgeons 3 years pre and post-training and compared them to non-LabCo trained surgeons. Pre-training, 108 LabCo delegates performed 4,586 cases in the, prior to training and 5,115 cases 3 years post-training. 796 non-LabCo surgeons performed 72,932 cases during the same period. Data included length of stay, 30 and 90-day mortality, reoperation, conversion to open and morbidity. The headline was that LabCo trained surgeons increased the rate of laparoscopic colorectal surgery by almost 40%, 21% more than non-LabCo surgeons. There were also significant decreases in the rate of conversion to open, re-interventions, 30 and 90-day mortality. In more detail, better formative assessment scores led to a higher use of laparoscopic colorectal surgery post-training. Higher scores in the summative assessment tool as well led to an increased use of laparoscopic colorectal surgery post-training. And finally, higher training volume, more cases in other words, and higher frequency of training cases led to a higher rates of post-training laparoscopic colorectal surgery. So what do we conclude? For me, quality in surgery is all about training. A competence-based, hands-on, performance-managed, networked training program, as we see here, resulted in safe and transformational increase in laparoscopic colorectal surgery in England. Surgeons trained in this system saw a decrease in conversion to open, morbidity, mortality when in independent practice. Clinical outcomes long-term are better than those observed in their peers. This provides the highest level of evidence for the impact of an educational intervention through Kirkpatrick's levels. We also observed a strong relationship between the formative and summative assessment scores on the rate of post-training laparoscopic colorectal surgery. Health economic analysis suggests that the LabCo program was at least cost neutral through the shortening of the proficiency gain curve, fewer complications and reduced hospital stay. I'd like to give special credit to the Imperial College team led by Professor George Hanna in the Academic Department of Surgery at St Mary's Hospital in London. And his PhD fellows for this project were Danilo Miskovic, Susanna Wiles on the left in the center of the photo below, Hugh Mackenzie, Melody Nee, and team. I'd also like to credit some of our most successful trainers and trainees in the program. Jim Kahn from Portsmouth on the right-hand side. Melanie Feldman, who's a consultant and was a trainee in the program. She's from Cornwall. And Amjad Parvez, who was our most prolific trainer. Once again, thanks for the wonderful opportunity to present to WAGE today. I look forward to receiving your questions. Thanks.
Okay, thank you very much, Mark. Some of you might know that Mark is now the chair of JAG. So he's shown that he can transform training. So maybe his next role will be transforming endoscopy training. We're going to take a very, very short break while we sort out our backstage so that we can then have an interactive session with our presenters. So if you bear with us, we'll hope to be back in about 2 to 3 minutes.
Okay. Good to go.
Great. Welcome back, everybody. So we've assembled our backstage team who are all just chomping at the bit to get going with this discussion. We're going to start with the first question that came in, which was from Tony. No, it was from Bernard for Tony. Tony, you were talking about how you managed to get all your different units in Northern Ireland to work collaboratively. And Tony is asking, how did you do that?
So thank you, Bernard, for the question. I think that we are quite lucky in Northern Ireland in that most of us are pretty collegiate. We all know each other and we all get on well. And so I think there is a commonality in trying to improve services. I think from the practical point of view, what we also did was that by coming up with suggestions for quality improvement and service improvement, we made sure that this was a Northern Ireland-wide initiative rather than a trust-centric initiative. So that there are 5 trusts in Northern Ireland, and we made sure that there was a representative from every trust in the work streams. And we also kind of, at least in the initial stages, in fact, still now, we try to avoid the contentious issues and focused on things that people would agree with. So a contentious issue might be, for example, the number of ERCPs done per individual operator. So we kind of steered clear of that, at least initially.
Does that answer your question, Bernard?
Yeah, I think it's a really important point, though, to try and encourage people, departments, consultants, leaders, to think of the wider population and try and work for the greater good. I think too often we do find it's some individuals more focused on developing their own sort of personal practice or their own unit practice. And I think for the good of patients, good of the NHS, and we really do need to focus on the wider good for the whole population. And sounds like Tony's really helped to lead with his colleagues that process well in Northern Ireland. And again, we've heard in Wales from Andy in terms of the IQLS progress. Sounds like similar progress has been made in Wales. So it's good to hear.
Isn't that a slight danger, though, of having these frameworks that you are potentially going to set units against each other? A little bit like the JAG accreditation, that there is obviously kudos attached with being approved, or gold, silver, bronze, etc. that you were talking about with your quality service frameworks. Is that a bit of a worry that you might create competition rather than collaboration?
Well, one of the things that we are very focused on is to try and make sure that there's collaboration between smaller units and large units. So we're trying to build the framework so that, for example, for GI bleeding, what you might need to achieve for a smaller unit may be very different from a large unit. A large unit, to achieve the higher standards, they're going to have to demonstrate that they are supporting the smaller units with, for example, interventional radiology or TIPS service, depending on the size of the unit, and that they should have clear pathways and processes in place, a clear protocol to accept referrals from the smaller unit. So in each system, we're hoping that we will encourage a collaborative behaviour by building that into the framework. If you go onto a wider scale, so that, I suppose in Wales that would be between health boards. To some extent, maybe it is healthy competition, but we would hope that people would work together to try and help each other get to these higher standards. And it's meant to be in the same way that IQLS was described by Andy. It's meant to encourage each unit to gradually build on their developments as they go forward. And in the same way as GRS, you could start off perhaps with hitting bronze in half the standards, and then the year after, hopefully you hit it in 3/4 of the standards. And as long as each unit is seeing its own progression, hopefully that will encourage active participation and further work.
Great. Can my battery's about to run flat on my laptop, so I'm going to go and plug it in. John, are you there? Can you take over the questions for a minute? I'm so sorry.
Never a dull moment. No. So I think there's one other question here, which has come around to you, Tony, from Bernard again about the ERCP work and linking in with different specialities to agree sort of standard surgical approaches.
Yeah, thanks, Bernard. And another very good question. So, what we in Northern Ireland do is to follow the BSG guidelines. And as you know, with the common bile duct stone guidelines, the recommendation is that either laparoscopic exploration of the bile duct or pre-operative ERCP is acceptable, depending on the expertise available locally. So we do have our own local guidances and processes depending on the ability of our local surgeons. We also have a regional HPB unit where some trusts that do not have the surgical skills for laparoscopic bile duct exploration would refer centrally to the regional center, and there's also regional HPB MDM for malignant disease. So all malignant pancreatic biliary diseases are discussed centrally and may be treated locally depending on the expertise.
Brilliant. Thanks, Tony. It's always good to hear from Northern Ireland, which I always, from my work with JAG, always felt was very similar to Wales in lots of ways in terms of the challenges and the way services are delivered and organised. So good to see you and good to hear from your experiences. Shall I just take Andy's questions, Joe? Shall I take the 3 Andy questions and then hand back to you? So Andy, you've probably read the 3 questions that colleagues have asked you. Anybody in the audience who wants to add any additional questions to the chat, please do, or you could raise your hand and you can actually do a live question. So 3 questions for you, Andy. First one, congratulating on your lead, which we're all proud of you and your achievements as IQLS lead, another lead from Wales, doing good things across the UK, so good man. What's the time commitment for filling things in for accreditation? Because there's often a big work burden for doing anything to do with accreditation work. What's your response to that?
Absolutely. First, to say I'm the quality assurance lead, so James Ferguson remains the overall clinical lead. But just for clarity, but yeah, I think Tony, it's a really important question. I think one thing we thought in the early stages when we were embarking on this within Wales is we recognise you need to carve out dedicated consultant time to lead it, and actually you need dedicated CNS time as well to help support that process wherever possible. But we did fund a consultant, or we still continue to fund through the national strategy, which we're lucky to have, a consultant lead session per health board. And I think without that, I think we would struggle to have made the progress that we have. And I think there's still challenges even with that time. So I think you do need some headspace time to be able to develop these things for sure. In terms of the total time to work on this process, it's very variable. I think it depends on where your setup is at. I know you've got a brilliant unit up in Belfast there with Johnny Cash and Neil McDougall and people like that, and they might take less time than perhaps a smaller, less established service. So I think it very much depends on your existing staff base and existing size of service. But the key bit is, I think, having that dedicated consultant time to think about it, to plan it out. But then crucially, you have to have regular business meetings. They don't have to be long, 45 minutes to an hour, where you discuss the key points so that you maintain the momentum, because we're all extraordinarily busy and things will just slip periodically. And I think Bernard made the point as well, this is a slow process that needs to be ongoing, and it's a marathon, not a sprint. And I think, sometimes there's a rush to get accreditation. If you're making progress, if you're engaging with the framework, you are getting better. Even if you haven't had a level 1 or level 2 accreditation as it exists within iQuils, you're still making progress. And I'm very keen to try and promote that to people, to say, don't be put off if it's slow. You can only go at the pace you can go if you've got limited time. But if you're engaging with the framework and you're working to those standards, you are getting better week on week, month on month.
Thank you, Andy. And then 2 very quick ones, actually. One was just saying about, have you considered sharing any of the practice through BSG meetings and stuff? So that's a really good question, actually, Ben. And because I'm sort of new to the sort of iQuils sort of team, I'm not really, I don't think there's a formal process for doing that at the moment. Now, clearly, examples of good care will probably be submitted through different either regional or national meetings sometimes, including the BSG. But one of the things I'm quite keen to do as the QA lead, giving James Ferguson a bit more headspace to do the very high-end stuff, is to try and collate those exemplars of good practice and try to bundle them into an annual report, because there's the skills framework that sits within the iQuils online platform. But I think sometimes publishing a report every year just saying, actually, this is what the iQuils assessors team, the trained assessors feel are examples of high quality care, and how you can go about delivering that. So I think almost an excellence in care and innovations report every year, I think, would be a good addition to the iQuils program, so that people could, and that's a good hook in then for people to sort of engage with the service, whereas previously they haven't done so. A lot of people think it's a huge administrative burden, but actually when you see some of the gains that can be made, I say the big one for us was just appointing a band 3 healthcare support worker to do our fibre scans. Our waiting times just plummeted. Now any manager is going to want to see that, and is going to see that as a very attractive option, and that's a good hook for them to try and get management engaged with these schemes where perhaps they're struggling to do so before. Just one final thing from me was just to ask whether there's anything Welsh specific in your iQuils, whether there's any tweaks. We got a few tweaks from JAGS for Wales, just towards Welsh standards. Is there any iQuils tweaks for Wales?
We haven't dragonized it yet, John. I think, will we? I don't know. Maybe my influence will drive. I don't know. I think the iQuils standards are very different to probably JAG in terms of they're a lot less detailed, and that reflects the maturity of liver services compared to endoscopy services. And it may change over time, but I think at the moment the standards are fairly generic. And I think that they don't speak to any major differences between the approach we should be taking across the 4 home nations. So there's no particular desire to do that. What we're very keen to do within Wales, and use Wage as a conduit for this, is to perhaps share some of the logistics and some of the challenges about how we can get to those points, and particularly on business cases, because those sorts of things should be common across the NHS in Wales when they go to banding and matching and all those sorts of processes. So we're keen to make it as easy as possible for colleagues across Wales to sort of take the next steps, but there's no particular desire to dragonize the process just yet.
Thanks, Andy. Diolch. I'm going to hand back to Joe, whose batteries are now charged, I think, so you can take over, Joe.
I'm back on mains power. Oh, it's been fun this afternoon. We'll move on to the next question, and this is for Bev. Your presentation was brilliant. You've done so much work, very impressive. The question is from Tony. How do you think your GIRF visits and metrics can align with the BSG quality framework as described by Bernard?
Yeah, I think it's a really good question, and I think it does align in that really a lot of the data pack we did was trying to focus on what's best for patients. So it still fits with all your sort of get in, get diagnosed, get fixed, get out, get on. So we were looking at, things like emergency admissions. So, how could we have prevented it? How could we have got people into the service in an elective, controlled manner, which is better for them than ending up through A&E? How do we make sure we've got the ability to, scope in a timely fashion, or 7 days a week, that kind of thing. So they're sort of getting diagnosed, getting treated. And also they're trying to reduce length of stay to sort of get people out, and making sure that we are continuing to monitor and follow them up so that they don't end up with lots more emergency admissions. So I do think it does all align. And I think the nice thing with the metrics and being able to then end up with things on Model Health or Model Hospital is that trusts might actually be able to see, as they work through those quality standards for the QI programme, that their metrics should also start improving in the GIRF programme. So, and sometimes it's those metrics that help trusts and trust boards understand the value of what we're trying to do, because reducing emergency admissions and reducing waiting times and all that does actually reduce costs, because you'll have less complications, less complaints, all of that kind of thing. So I think it does align well.
Is it going to be an annual process then, the collection of these metrics?
Yeah, no. I don't know if I'd ever have the energy to go right around the country all again, but I think the idea is that we're now trying to move to a model where we can refresh data more regularly, because the data gets old. Doing the GIRF visits using the same data for 18 months, and yet you're using data from things like HES that was the previous year. It took a year to design the data pack. It's very labour intensive, actually trying to test it and look for different data sets, and then when you look at the data, you often find that there's flaws in it. There's lots of different ways you can code the same thing, so finding out which codes you've got to include or not include. So doing the data pack took a year, and then the visits took 18 months. So the data gets old all the way through that. It didn't seem to matter with the visits, because they felt that actually it's useful to know where you benchmarked at a point in time, and you allow a discussion to see whether things have improved in that time. But the idea now is we'll move to a system where data might refresh quarterly Model Health, so that again we'll pick some key metrics and sentinel metrics, and trusts will be able to sort of see their progress much more easily.
Okay, so I lost you a tiny bit there on what you were saying, but I think we got the gist.
Sorry.
So the next question, Beverly, sorry, is I think it's an observation more from Miles Allison. He's willing to bet, he doesn't say how much, that the greater than 3 standard deviation scraping viruses as emergencies cover areas with high deprivation. So social deprivation something that you did look at?
Yeah. Yeah, we did. So in the data pack, the data pack in the end was 84 pages long. And the first part of the data pack is all about the demographics of the trust, of the population they serve. We also had with the questionnaire information about workforce. So again, it becomes easier to interpret data when you can see, how many staff they've got, whether they've got specialist nurses, whether they're looking after an older, frailer population. It's really good doing the visits, face-to-face or virtual, that they can interpret the data with you. So trusts will often say, if they're serving a much older, frailer population, or a population where there's a lot of English as a second language business, and that they may find it's harder to engage patients sometimes in follow-up. So it was really useful interpreting the data with centres, but sometimes it's trying to get them to see that they still need to change. So if it's that they're dealing with an older, frailer population, have they adapted their service to cope with that? Or if English is a second language, have they got ways, have they got, different information leaflets in lots of different languages? Do they have a specialist nurse that can contact patients in their own language? Is there a way of trying to help when people DNA?
I keep forgetting about the mute, I'm so sorry. The next question's in from John, Bev. It's to you as well. John, do you want to expand?
Bev, I had a sneak preview report a while ago. I think I got it through sort of JAG channels, and it's fab.
Yeah.
It's a big document. There's a lot in there, and it shows the volume of the work you've undertaken. But there's lots of really great. If you read through it, specific measures which you think, blimey, that's we need to get on and look at that ourselves and move it to our own service. I know Hayley, who's our president and the NEP lead in Wales, has already made contact with you, because my questions really are around how can we get into this sort of thing in Wales, because we don't have we don't have a dragoned version of GIRFT. How can we do it, and how would you take it forward in Wales?
Yeah, I think the difficulty often is getting the initial data, because that really was very labour intensive. So you'd need, that sort of IT analytical support, because you really need the data pack to benchmark trusts to then be able to have those clinical conversations. I know that GIRF were trying to look at, supporting the 4-nation approach and can lessons learned, like, offering to talk here at Wage, is trying to disseminate the information that we've learned. But I think it's how you get that initial data. I think the methodology, once you've got the data so that you can, let trusts see where they're benchmarked. Because what seemed to happen with the visits, I don't think I told any trust anything they didn't already know. But I think what happened was you were reinforcing and giving leverage to what the consultants and the specialist nurses and the teams have been asking all along. And you were helping trusts see the consequences of some of their decisions, like we haven't a money for a nutrition nurse. And then you say, well, do you realise your length of stay and your, mortality figures, or your, the issues that you end up with, your admissions and readmissions? It's so much more expensive than doing it right the first time. That actually the trusts were just being very grateful at the end that you were able to fight that argument for them and make trusts realise that it is important to invest in the staffing and the services to try and make care more planned.
Yeah, I think Tony's next question was very similar to what you just addressed, that really it's all about getting the data and how difficult that is. And I think certainly in Wales, that's kind of a big issue for us.
So
we don't even
have the data. So in terms of the trusts themselves, I mean, really, they don't have to do any work for the visit. They don't draw the data themselves. They did have to fill in the questionnaire. So someone at the trust, we sent that out in June 2019, and there may be a bit of data left, but only data they may also, do you monitor infection rates? So have you got information about 30-day mortality for PEG, that kind of thing? We didn't actually ask them to collect any data. The data pack is set by us from GIRF, so we give the trust their data and show how it benchmarks to the average across England, so where they are in those data, in those funnel plots. So actually a trust could do nothing other than fill the questionnaire in. Other trusts actually, because we send the data pack out about a month before at least, so some trusts have been really good at going through their data pack with their teams, looking at where there were outliers, looking at why they thought the reasons were. So some trusts had done a fair bit of homework on the data we sent them, and that perhaps made the visit more helpful for them, I suspect. Whereas other trusts, you literally could just turn up and we present the data and talk it through with them. So really the trust didn't have to invest anything, if they didn't have it.
I from my experience, I'm not a gastroenterologist, I'm a colorectal surgeon, and this is all very reminiscent of our peer reviews, which we do for the cancer MDTs. So it is a very similar process, and I guess we've used it also as a tool to get our health board to do stuff for us where we've got gaps in the service. It's very, very important to use it in that respect. Thank you, Beverly. I think we've exhausted you now. Should we move on to Mark? We've got Tony's asked a question, Mark, which is that he presumed that the LAPRO programme was voluntary. Could it be argued that those who took part in it were more motivated and hence the subsequent better outcomes?
Thanks. And it's amazing to reflect on the sort of conjunction of what Brett and Beverly were talking about together with Jag, how much process around quality assurance there is in gastroenterology and GI services in our country, and it's certain that a lot of other systems look upon us with awe and envy. So keep up the good work. It was not strictly voluntary, Tony, to answer your question, in that we helped our Department of Health rewrite the peer review guidance for surgeons who could or couldn't do laparoscopic colorectal, unless you could show you were
He was just getting to the good bit. I wouldn't like to second guess what he was
you
saying.
could not
either.
perform it outside of the
Oh, it's
training
back.
program. I'll just stop there
Mark,
a moment
we
because I
missed
think I've
you,
lost
I'm afraid.
everyone.
You're back now. Can you start again?
Hello? Hello, did you... Sorry, can you hear me now?
Yes. Yes.
It was regulated, Tony, through the peer review system in that you had to prove you had been properly trained at the time, or you couldn't perform laparoscopic colorectal surgery, and that was put out through the peer review guidance for cancer MDTs. So it really was left for consultants to require to come into the program and be trained during the time that it was in existence.
Mark, is there any ongoing quality assurance, essentially? The trainers that were trained, that have obviously now trained the trainees, are we checking the quality of the trainees now? Do they get assessed?
Yeah, I mean, that's a good question. And there's a fairly universal, reasonably robust system called the ISCP, which is the Intercollegiate Surgical Curriculum Project, which is run by all the Royal Colleges, in which and it fits in the framework of the ARCPs through the schools of surgery and the deaneries, but it isn't specifically around laparoscopic colorectal, and it doesn't, unfortunately, unlike our program, provide you with a robust learning curve accompanied by analysis of clinical outcomes to prove that during training that trainees are acquiring skills appropriately, and at the end of training that they have in an identifiable and transparent way obtained those skills in order to practice independently. But yes, there are systems to answer your question.
Thank you. Does anybody on the panel have any other questions? John, you're waving.
Yeah, Mark, I know it's probably not strictly fair because we didn't ask you specifically to talk about this, but in terms of your JAG role, now we've got you in front of us, you very kindly joined a call with us a week or two ago talking about JAG in Wales. Just wondered if it's possible for you to give us some overview from your JAG chair position about what you feel we should be, what the way forward for us in terms of getting our units accredited, which is one of our National Endoscopy Programme goals. Whoops. Looks like we've lost you again. Sorry, Mark. Give it a second just in case that comes back, Mark. Hello, Mark.
You're all coming back. Can you hear me now?
Yes, we
Somebody
can.
put a thumb up. So I think I
know I shouldn't be laughing, but
I think the modicum of reassurance I have is knowing
certainly ahead of
that the internet,
you know, some of the devolved nations in terms of you know, buy-in to the accreditation process. So the first message is to keep doing what you're doing, to encourage unit to see it as part of a process that Andrew's alluded to. It's not about getting over the line. It's about seeing what needs to be done and getting everybody in the unit to see the benefits of accreditation, which are fairly transparent. If they don't know them, they're available through the website, and to see what aspects of unit policy and practice and procedures can be improved to align themselves with the JAG accreditation standards, and in doing so, you know, units improve, and I think the ethos of units and the working practices of units and just the general morale of units will improve as a result. And I mean, looking at social media, it's evident that there is great pride and joy when units obtain and retain JAG accreditation. So you know, I'd say just the more we do this kind of stuff, the better for everybody, and of course, the better for our patients. That goes without saying. Thanks for the question, John.
Great. I just wonder whether there's anybody who, anybody out there, but anybody who wants to ask us anybody on the panel any last questions, or in fact, if anybody on the panel wanted to ask each other any last questions before we wrap things up? If there is, either audience put your hand up virtually, or panel members put your Aaron's, there's a question here, Mark, for you here. Can you read that question, Mark? Can you see it on the screen?
I'm just on the wrong screen at the moment, but I'll switch across to questions.
I'll speak it. I'll read it out for you. Yeah, it's from Aaron, who's one of our colleagues from North Wales. I'll wait till you've. See if Mark comes back in again. That's a good question, actually.
If you can hear me, I can't hear you at the moment. Sorry about that. I'm just looking for the question.
Mark, shall I read it out to you?
Yes, if you would.
Yeah, it's from Aram, who's one of our consultant gastroenterology colleagues from North Wales. And he said, considering the issues with training numbers, particularly compacted by COVID, is there any plans to reduce lifetime numbers for competency, aiming more for skills achieved?
That is certainly something we've discussed, and referencing the entry criteria for screening endoscopists, because we recognise that there's
we should just give it one more go, Joe, and then
screeners. Sorry if I've lost you again. This link is dreadful. Maybe it's an England Wales thing, but I'll keep talking. With respect to the can you hear me? It's a bit frustrating. I've not used AirMeet before, but I'm not a big fan, I have to say. So yeah, we're talking about it. I mean, I think the general thought is that we should keep the standards that we've got, because again, you know, we are the envy of the world when it comes to implementing standards and training quality in endoscopy, and we shouldn't drop the ball on that. But I think, you know, the next move should be to, certainly for things like entry to become a screener, should to be assessed on competence rather than simply numbers. I think you're right.
We know that the new curriculum for the surgeons is changing in August.
Say is that yes, we've replicated colorectal training programs in Norway and Denmark, a gynae program in Australia, a general surgical program in the United States. We're looking to do a gynae program in Poland. So aspects of the program are indeed being replicated in other systems and in other specialties. Thanks for those questions.
Brilliant. John, do you think we should bring the session to an end?
I think unless there's anybody's got any last things typed in or hands up on the panel, I think we've got a few, as you say, it could be England Wales things, or it could be NHS cabling, or whatever it may be. Bernard's got one. Yeah, Bernard, go on.
It's not really a question, it's more of a comment. I think I've really enjoyed all the other speakers. Obviously, all of this work is aligned to the same thing, to try and improve the quality of the service we deliver for patients. What we've got to do together is try and make sure it's as aligned as much as possible, that we make sure that we can share the good practice. So that's one of my questions, obviously, to Andy, was about the area where places have already delivered, say, good outpatient paracentesis. Let's put those examples out there. Let's put the business cases out there. Let's help everyone to try and improve the standards by sharing what already works well. And I think Bev's already found in the Get It Right First Time work that there's plenty of places around the country that are achieving great things in particular areas. And if we can replicate that, we don't need to reinvent the wheel. And I know Tony was working on that with the quality standards framework before me. So I just thought I'd make that comment.
That's a great closing statement for the session, actually. I think that wraps up things really well, thank you. So, Joe, would you like to sort of wrap things up and say thanks to yourself and Hayley?
I think you just said it for us. Thank you to all our speakers. It's been a really interesting afternoon. I've learnt loads about things that I had no idea about. It was great. And I've learnt a lot about IT and platforms and how to use my phone as a hotspot, which wasn't terribly successful, but never mind. So yeah, thanks to giving up your time. Your presentations that you gave, that you prepared in advance, were very good. Thank you very much. And thanks for all linking in with us to answer questions. So we're going to hand over to Hayley for closing comments. I think, is that in a fresh session?
I think we can do it now, Joe. I'm sure
Right.
everybody's ready for a cup of tea. Is that okay? Okay, well, just to echo Joe's thanks, really. Thank you so much for all our speakers today. Some really excellent sessions, and thanks to the chairs for these sessions and also for the rest of the week. So I think we've had some really excellent talks, and I hope you've all enjoyed it. Thanks too for bearing with us with our IT issues, and it's certainly been a learning curve, and we are going to reflect on this platform and think about what we do for the conference in October, and very much look forward to the time that we can actually get in a room together. So any feedback on this platform, would be really grateful for that. So let us know what you think. Arwen will be in touch shortly with the evaluation survey. Be really grateful if you could complete that honestly. Let us know what you thought of this session and what we could do to improve ready for the October conference. So the October conference is going to be 6th and 7th of the month, and we'll be in touch with more details about that shortly, and also about the monthly sessions that Joe mentioned earlier. So the next one's going to be on the 1st of June, so hopefully you'll be able to join us for that. We'll also be in touch with your CPD certificates, and just really like to say a really big thank you to Arwen and Adam, who've sorted this out this week, and I'm sure they've aged this week. It's been an incredibly stressful time for them, keeping us operational, but as always, done a fantastic job. So thank you both. And thanks very much to everybody that's been involved in developing and delivering this conference, and most of all to you for joining us. So we are going to be in touch shortly, but in the meantime now I think we'll close this session, and I can't wish you all a safe journey home because a lot of you are already at home, but thanks very much for joining us, and we will hope to see you all soon. Thank you.